Hello, my name is Dr. Erik Wilson. Today I'm going to talk about revisional bariatric surgery in this webinar with Memorial Hermann Hospital. Welcome people as they listen in. As many people know, bariatric surgery is a very growing and rapidly advancing specialty around the treatment of obesity. And since so many bariatric procedures have been done over the years now, there are patients that have problems with their bariatric surgery and need to do something else. So let me introduce myself. Like I said, I'm Dr. Erik Wilson. I'm a professor of surgery at the University of Texas Medical School and UT Health. I'm the Bariatric Surgery Medical Director for Memorial Hermann and the Memorial Hermann Hospital System, and the division chief of our minimally invasive and elective general surgery group at the University of Texas Medical School at Houston. So as you can see from this graph, which is an old graph, it shows continued growth of bariatric surgery. And bariatric surgery now in the United States is about 200 to 250,000 cases per year. So there's a lot of people out there that are seeking bariatric surgery as a solution to help them with maintaining weight loss. So I'm going to talk about how that works, and then if you have a problem from bariatric surgery, what do you do about it? So I think it's important when you talk about problems from bariatric surgery that you also put a context around it. And so the first few slides actually look at why we even do bariatric surgery to begin with. And there have been several studies now, and this is just one of them, but there have been several studies now that show a significant reduction in death in patients that get bariatric surgery over those that continue to stay morbidly obese. So if your body mass index is high, and a body mass index is a ratio of your weight to your height, and something that's considered abnormal is over 25, but when you get over 30, you're considered obese, and over 35, morbidly obese. When you're in a morbidly obese range with a high weight versus your height, you have a high chance of dying from health problems related to obesity. And this study shows that 6% of people who didn't even have any significant health problems, 5 years later, 6% of them had died at that time. And then it was compared to patients who had bariatric surgery and the number of people that died after having bariatric surgery at 5 years, and it was much less than 1%. So you almost see a tenfold reduction in mortality between those who didn't get bariatric surgery and those that did. So bariatric surgery saves lives. There have been several other studies, large studies, have now show that people live longer on average compared to those that don't get bariatric surgery and stay morbidly obese. So bariatric surgery is very, very beneficial. If you look at all the health problems related to obesity, they get better in every category. The risk of cancer drops, the risk of infectious diseases drops, musculoskeletal problems such as arthritis improves, endocrinological disorders, such as diabetes, they all substantially improve. Cardiovascular disease substantially improves. Respiratory problems, even mental issues such as depression and mood disorders improve. The only thing that gets worse significantly after bariatric surgery is your gut becomes more sensitive, so you have more problems with your digestive tract, because when you mess with the digestive tract to make people lose weight, to make them have less of an appetite, it does have a side effect. So when we talk about bariatric surgery, we tell patients that we can make everything better to some degree if they participate in the program and work hard with us, but their digestive tract is more sensitive. So that's the downside of bariatric surgery. How does bariatric surgery work? It induces satiety is really all it does. That's what I tell patients when they come to see us. We're not really doing anything to cure your obesity. It's a tool to help you lose weight, and really all it does is we work on your intestines by rerouting or adjusting the intestines, by putting a band on them, cutting on the stomach, cutting on the intestines in some way to make you feel less hungry. That's really its job, is to make you feel less hungry. Your job as a patient, if you get bariatric surgery, is use that lack of appetite to help you lose weight. And there's ways you can eat that improve your sense of hunger relief, and those that can make you more hungry. We often talk that bariatric surgery uses two key components: restriction and malabsorption. Malabsorption being working on the intestine and bypassing the intestine. Restriction basically means choking off the stomach or making the stomach smaller, so you feel more full when you eat food, and therefore eat less. And those are a little bit oversimplifying the issue. Really what happens is there's hormones that get changed in your body and your metabolism gets changed as a result of these hormonal changes, and you have an increased sense of fullness and you're less hungry. So what we do, we induce satiety when we do weight loss surgery by adapting the stomach or the gastric chamber to induce emptying, reduce the activity of hormones in the early part of the small intestine, and stimulate hormones in the distal part of the small intestine. And one of the fundamental problems, the reason that obesity is such a large problem in the United States, is that the type of food we eat works exactly against this. It's a type of food that doesn't cause the stomach to empty well, doesn't fill up the stomach, overstimulates absorption in the upper part of the small intestine, and doesn't allow for any absorption in the lower part of the small intestine, so that doesn't get stimulated and people don't feel as full. So when you talk about weight loss treatments, there's a whole different types. There's surgery up on one scale, and then there's medical therapy and pharmaceutical therapy and behavior modification down on the other side of the scale. There's also a whole host of treatments that are being developed in between that, and we call these like endoscopic or endoluminal procedures, and there's actually some revisional procedures that are being developed in between this, and I'm going to talk about that a little bit, because when we do revisional procedures, these types of procedures are lower risk, but can actually help revise or improve some of these surgical procedures. And then use of pharmaceutical, medical therapy, behavior modification is all very important in order to achieve success with bariatric surgery. So we should work harder to combine our efforts between all the different types of treatments. So really you have three types of treatments. You have things you can do down the mouth with endoluminal work. You have medical therapy, behavior modification, standard kind of diet and weight loss structured programs, and then of course you have surgery. So we need to work on combining and utilizing all these together. And in our program at the University of Texas and with Memorial Hermann, what we do is our best to use all of these modalities to help people achieve a better sense of fullness and lose more weight. So bariatric surgery is a tool to control the chronic disease of obesity. It does not cure obesity. Like I said, it's basically changing the gut to help induce a sense of fullness when eating the appropriate type of food. And that's an important thing to know, because when we're talking about whether you're successful or not from bariatric surgery, a lot of factors play into it, and the surgery itself is just one factor. So how do you even define whether you're not successful from weight loss surgery? So let's say you've had some type of procedure and you're unhappy. If you're unhappy, why are you unhappy? Is it because you didn't lose as much weight as you want to? That's a common complaint that we get from patients. That you're not as healthy as you want to. That's a less common complaint, but actually a very important issue. And is your quality of life improved? So really bariatric surgery hopefully makes you lose weight, improves your health, and improves your quality of life. So if you don't achieve some of those, then you could say, well, maybe the surgery hasn't done everything we wanted to do, or you haven't been as successful with the surgery as you want to be. But it's hard to say a patient is a failure if they haven't lost as much weight as they want, but they're still significantly healthier. So it's hard to firmly establish a definition of failure versus success. And so we look at it in the eyes of the patient. How does the patient feel that they're doing? And if they're significantly healthier, but they still want to lose more weight, we acknowledge that, but we may want to make sure that their expectations are appropriate for what bariatric surgery does. Bariatric surgery does not, in general, cause you to lose all your extra weight. There are people that get bariatric surgery and lose all their extra weight, but that's not what the average procedure does. Most procedures cause you to lose some weight, and then you can actually slowly, over time, gain some weight back. And this is a graph that basically shows what happens when patients get weight loss surgery or they go through a massive weight loss phase, that they can gain weight back slowly over years. And there's a lot of bariatric procedures where patients will lose 2/3 to 3/4 of their extra weight, and then if you look at them 10 to 15 years after the procedure, that's closer to half their extra weight. And I think what's important to note is if you look at a patient that didn't get bariatric surgery and didn't have any surgery at all, they probably would have had some weight regain anyway. So instead of comparing your weight at the point before you had any procedure at all, and then looking at it years down the road and comparing it to how much weight you regained, you should probably compare where you potentially could have been without weight loss surgery versus where you're at now. And I think that's probably a fairer judgment. So I think it's important to establish expectations around that. When patients have problems from bariatric surgery, we kind of look at three variables that can play into that. Medical factors such as structural and mechanical things with the tool. Has the tool have some issue? Is the band slipped? Is there an abnormal connection between the upper and lower stomach? Are there nutritional deficiencies? Issues like that. Then there's other factors that play in psychologically. Is the patient not really physiologically very hungry, but still eating more than they should be because of some emotional eating or a food addiction behavior? We have psychologists that we work with pretty extensively around trying to optimize the emotional ties to eating and making sure that we're dealing with food addiction issues. And if a patient gets a revision, oftentimes we're encouraging them very aggressively to participate in food addiction classes and food addiction groups, support groups around food addiction, to understand what are their issues with their food psychologically. And then there's important educational issues. Sometimes patients have bariatric surgery and they weren't educated properly about what to do to be successful with it. I've run into a lot of patients who have had bariatric surgery in other locations, and they come to see us and they tell us they've never been told that they were supposed to eat this way or that way. And so I think good education and re-education on patients that have had previous bariatric surgery and are struggling is very important. So just to give people a sense, because people wonder, well, what if I have to get a revision? Am I a failure if I have to get a revision? I'd say the answer is probably no, because there's a large percentage of patients, depending upon the procedure they get, that have some type of problem with that procedure. And if you look at these procedures such as LapBand, gastric bypass, sleeve gastrectomy, even biliopancreatic diversion, or some of the older procedures like vertical banded gastroplasty, a decent number of those patients end up getting revised to something else. And if you start adding up the numbers, it's easily over 50,000 cases a year that potentially are going to have to be revised when you look at the number of cases that are being done. And if you look at websites that have the Google search Revision Bariatric Surgery on them, there's a lot of websites that refer to that. It's important to manage expectations, though, if you're going to revise somebody into something else, because what we've learned is that the enemy of good is obviously perfect. So if a patient's doing really, really well, but they are not happy because they've lost only 60% of their extra weight and they really want to lose 90% of their extra weight, they need to be reminded, well, the operation may have not ever in them given them 90% extra weight loss. So we actually did a survey many years ago on patients that wanted bands, and we asked them what they expected to lose and calculated out this percentage expected weight loss. And patients who came in and wanted bands in our practice, they wanted to lose 80% of their extra weight. That's really what they wanted. But a band, on average, you lose about 40 to 50% of your extra weight. A really good band patient will lose half their extra weight, which is a good amount of weight, but not close to 80%. So if a patient's expecting to lose 80% and only lose 50%, they could be very unhappy, even though that's a really good result. So you have to match the operation to what the averages are, and then match the patient's expectation. Another example of that, a bypass. So a lot of people talk about bypass. Well, it's a more aggressive operation with better weight loss. So when the patients come in and want that, they expect to lose 90% of their extra weight when we surveyed them. In actuality, it's closer to 60 to 70%. And when you get about 15 years out, it's probably closer to 50%. So you do have to evaluate the mechanics of the tool, evaluate the patient's compliance and education, what do they know about how to use their tool effectively, and their psychology, and then manage their expectations and making sure that they understand what the procedures can and can't do for them. So why is this such a problem anyway? I'm going to talk in detail about some of the behavior modifications things we go through when we're talking to patients about revisions. But I want to, and then I'll go specifically into the different procedures and how we revise them. But one of the fundamental underlying problems is we've had a lot of changes in our society, and obesity is become quite an epidemic. Every state in the United States has a huge percentage of patients that are obese now. There's really no states left anymore in the United States that have an obesity rate less than 20%, and a lot of them are approaching 30%. So why is that? Well, there's a lot of things that have changed, but the biggest thing that's changed is our food, probably. Our food is pre-digested. We eat a lot of fast food. We eat a lot of food that is pre-processed and processed to the point we absorb it very, very quickly. And it affects the level of fullness that we have, because if calories don't reach our lower intestine, things such as these types of foods that you get in the freezer section of the grocery store, or when you go out to eat fast food or highly processed food, they absorb so quickly in our upper small intestine that they don't reach our lower small intestine. And then the hormones in our lower small intestine don't get fired off that tells us we're full, and therefore we're more hungry. So the type of food we eat basically makes us more hungry, and we eat more of it. So the food that's out there now is designed to make us want more of it, but not necessarily make us feel full, and we eat a lot more of it. So when we ask what to do when a patient has bariatric surgery and they're not happy, and we ask it within the context of, well, this is a tool to help the patient lose weight but not a cure, the obvious question then becomes, are we using the tool well, and is the tool working as it's supposed to? So that gets back to what are the mechanics, and does the patient understand how to use the tool? And then it's supposed to be performed, bariatric surgery is supposed to be performed with a lot of support around it, with a comprehensive program helping out the patient. And then the question often comes is, are we using that team? Is the patient seeing the dietitian when they have problems? Have they been to a trainer? Have they been working out? What are they struggling with psychologically? Have they had an emotional issue that's caused them to look to food for support as opposed to some other outlet or coping mechanism? So all of that needs to be evaluated. And when you do pure medical weight loss and you're morbidly obese, less than 5% of patients end up having a long-term maintenance of their weight loss. But if you combine surgery and medical weight loss together, it's actually much more powerful, and that's what we're doing. So we have a medical weight loss specialist in our clinic who does medical weight loss and works with our patients both preoperatively and postoperatively, and with patients who don't want surgery at all. So I think medical weight loss can be used in conjunction with surgery very, very effectively, and can really improve the outcomes of surgery. So let me talk a little bit about nutrition, because I think this is important for patients to understand how to be successful with bariatric surgery. And sometimes just re-education can get a patient back on track. And so if you're listening to this webinar, maybe if you just think about a few things, this might avoid you having to get any more surgery. So let me talk a little bit about the types of calories that exist out there. There's three basic types. Actually, there's four, and I'm going to mention the fourth here in a second, but there's three basic types of calories that we put in our body: fats, proteins, and carbohydrates. Okay, fats can be processed to fat or energy, meaning once we eat them, we can turn them into fat, or we can utilize them to give us energy. Proteins can be processed to muscle or energy. It's pretty hard for them to be processed to fat, but that can happen, but you have to have a whole bunch of extra protein for that to happen. So generally you build muscle, or they're utilized for energy. And carbohydrates can be processed to fat or energy. Simple carbohydrates are processed quickly and don't induce a lot of satiety. Complex carbohydrates are processed slowly and do induce more satiety. So those are the three basic types of calories we take in. Fats are very calorie dense, meaning there's about 9 calories per gram of fat. There's about 4 calories per gram of protein and about 4 calories per gram of carbohydrate. So when you eat a certain volume and it has a lot of fat in it, you're getting more calories, because per serving there's more calories per that size versus carbohydrates and proteins. But there are also some value to fats, because fats also make you feel very, very full. They induce a lot of satiety. The nice thing about proteins is they induce a lot of satiety, make you feel very, very full, and they're not that calorie dense. They're only 4 calories per gram. The thing about carbohydrates is everyone says, well, they have the same amount of calories per gram as protein, so they should be a pretty good thing to eat as well. But the problem with carbohydrates, especially simple carbohydrates, is they don't make you feel full. So really the best food that you can eat of these three is proteins. Now I said that there was a fourth one, and the fourth one is actually alcohol. And alcohol is 7 calories per gram of material. So if you drink alcohol, it's 7 calories per gram. Compare that to fats and proteins. It's almost as calorie dense as fats, but in many ways it's worse than fats because it has no sense of satiety to it. So you can almost value these foods based upon how full they make you feel versus how calorie dense they are. And really the worst is alcohol. So when patients have bariatric surgery, we really try to steer them away from alcohol, not because we're overly worried about them altering their addiction model into something else and becoming alcoholics or anything like that. But the real thing is you should be extremely moderate with alcohol intake if you've had bariatric surgery, because it's a huge source of calories and can prevent you from being successful with weight loss, because it doesn't make you feel full and it's very calorie dense. So it's important to know about the density of all these different types of foods that we eat and what makes us feel full. So you really kind of are what you eat. If you eat food that's high in simple carbs and fats, which is high in calories and high levels of insulin get created because of all those carbohydrates, those high levels of insulin that your body produces push those calories into fat. And people often talk about, I have to get on insulin because of my diabetes. We really should try to avoid insulin in patients long term if we could. We need to have good blood sugar control, but if you're to the point where you're requiring insulin, that means that your body is insulin resistant, and that means more and more insulin is been produced by your body until the point your pancreas is starting to wear out. And that means that more insulin is circulating around in your body. So once a patient gets on insulin because of their diabetes, they're going to get fatter because insulin produces fat. So in overweight people who are insulin resistant, this creates a vicious cycle where the insulin makes sometimes their blood sugar levels start to go down a little bit. Patients don't like the feeling of being mildly hypoglycemic, and then they eat more carbohydrates, and it cycles again because it cranks out more insulin. And also the whole time while this is going on, the insulin's also generating fat. So I think it's very important to avoid a lot of simple carbs. And if you want to be successful with weight loss surgery, you should continue to do that. Avoid a lot of simple carbs, because simple carbs don't make you feel full. They stimulate an insulin spike, which makes you feel worse and makes you want more carbs. And they also, are a big source of calories. So how do we lose weight? Our calorie intake is less than if our calorie intake is less than what we burn, we lose weight. So basically, it is basic math. There's a lot of factors that play into that, because what we take in and what we burn are things that we have some control over and some control we don't. So we take calories in through protein, carbohydrates, fats, and alcohols. I didn't put alcohols on the slide, but those are the ways we take calories in. We burn it by two basic ways. We burn it through active metabolic rate and basal metabolic rate. Okay, what are those two things? Well, active metabolic rate is the calories you burn just moving around, going around, walking around, doing exercise. So if you're exercising a lot, you're increasing your active metabolic rate. When you walk around, that's active metabolic rate. Your basal metabolic rate is the calories you burn being alive. Basically, the calories you burn with your heart pumping, your lungs moving, all your intestines working, your skin maintaining body temperature, your brain working. All of those things are tied to basal metabolic rate. The thing that burns the most calories without you doing anything, though, interestingly, is the muscle in your body. The more muscle you have, the higher the basal metabolic rate. It takes a lot of energy to keep your muscle alive. So your muscles require lots of calories. So the way to have a high metabolic rate is to have a lot of muscle. Well, how do you get a lot of muscle? Well, you can be a dude, because guys have more muscle than women. There's really no way to control that, though. That's something you're born with. Or you can do something to try to increase your muscle mass. how can you increase your muscle mass? Well, you can eat protein and work out and produce muscle, and that can increase your basal metabolic rate. So you achieve weight loss by taking in less calories, having a high basal metabolic rate and a high active metabolic rate, which increases your burn versus your intake and causes you to lose weight. So active metabolic rate, like I said, you really kind of lose calories and burn calories by exercise. You can exercise, and cardiovascular exercise does achieve active metabolic rate. Pumping iron or doing some type of muscle training, resistance training, that helps you, that's active metabolic rate as well. But the thing about resistance training is it also affects muscle mass, which also in not only increasing your active metabolic rate, but also can increase your basal metabolic rate. So active metabolic rate is important just through exercise, but muscle training can help active metabolic rate and basal metabolic rate. So how can you control more muscle mass? Take in protein, be bigger, which you can't control, be male, which you can't control, but working out. Working out that involves getting your muscles sore. I tell patients, if you make your muscles sore a few times a month, you're probably building muscle, and you're probably going to have a better metabolism. So it's important to do resistance training as part of your activity. And I have lots of patients that come in and say, I work out all the time, but basically their form of working out is some type of cardio training. They're doing elliptical, they may be running even, or doing aerobics, but they're not making their muscles sore. So they may have well-functioning heart and lungs, and they're burning some calories when they do that actual exercise, but they're not building muscle. And building muscle is what keeps your metabolism high. So you can also improve your metabolism by eating the right types of foods. And protein helps you maintain muscle mass or build muscle mass. So if you're working out and eating protein, you'll have more muscle mass. So that's why we stress so much that eating protein is very, very important, because it builds muscle mass. But we also stress it because it achieves a way of making you feel full and reducing your calorie intake. Because protein is complex, hard to digest, so your body has to take some time to do it, and it usually sends signals to your brain saying, hey, I'm busy here trying to get this protein digested, don't send me more food. So when we talk to patients about always eating protein first, that is a way of getting patients to reduce their sense of hunger by eating the protein and feeling fuller. So if you go and eat a bunch of carbohydrates before you eat your protein, you'll just get a whole bunch more calories than if you eat your protein first before you went to any carbohydrates. Also, solid foods are usually better than liquid foods because solid foods are harder to digest, take more work by the body, and make you feel fuller. And staying hydrated also helps with making you feel full, because if you drink water on a regular basis before you eat, it's been proven with multiple studies that you have less hunger and you eat less. So we have basic long-term nutritional goals of 5 basic things. Stay hydrated, because if you drink a lot of water, you're less hungry. Eat protein first when you're hungry. That should be the first thing you put in your mouth, because if you put that in your mouth first, you'll end up eating less when you actually eat. Eat solid meals and divide them up into meals. Don't graze all day long. They should be meals. You should sit down and eat for a period of time. You should fill up, and then you should move on with your day. The number of meals isn't important as if they're actually meals, and you don't want to get to the point where you're eating 7, 8 meals, which actually ends up being just grazing. If you're grazing, you're never really filling up, and lastly, you want to avoid simple carbohydrate-based calories. Those simple calories do not make you feel full. They raise your insulin levels, and they make you more hungry very quickly. And also, I tell people is count some calories every now and then. There's a lot of great apps out there that you can utilize to count calories, and that can really help give you a sense of what your calorie intake is. And if you had bariatric surgery, your calorie intake long-term should be somewhere between 800 and 1,400 calories a day, which doesn't sound like a lot, but actually that can make you very, very healthy at that calorie intake and can maintain good weight loss. Then there's exercise goals. You want to focus on all types of exercises, and a lot of patients are really good at cardiovascular exercise if they are exercising. If you're not exercising, obviously you got to start exercising, but you just don't want to do cardiovascular exercise. You also want to do some resistance training, some high rep, low weight weight training that makes you build lean muscle, because lean muscle increases your metabolism. And if you make your muscles sore a few times a month, then that actually will help with your metabolism. And I have patients all the time say, well, I've got this problem with my joint, or my knee's bad, or my hip's bad, and I just can't work out. And I would say go to a trainer, and skilled trainers can teach you how to work around that bad joint and still achieve some muscle soreness where you can be successful. Now, there are trainers that can push you too hard and create joint issues, but you can find trainers out there that can work with you and have you achieve good muscle mass building without tearing up your joints. Okay, let me talk about the surgeries now. So these are the 4 operations that are out there as kind of standard accepted weight loss procedures, and I'm going to talk about the problems that can occur with them and what you do about them when those problems occur. If you look along the left side of the slide, you see a adjustable band or lap band, sleeve gastrectomy, gastric bypass, and duodenal switch. They go in order of lowest and simplest procedure to do to the most difficult procedure to do, the least risky to the most risky as far as nutritional risk and operative risk. But as you notice, as you go up in risk, you also go up in average excess weight loss. So the procedures that are more complex, that are more difficult to do, and have a little more risk, are also have much better weight loss. So that's the balance. There really is no one perfect bariatric operation, and obviously you can see any of these operations can have problems, but you're trading off operative risk for potential average improved excess weight loss. So let's talk about bands first, because when people come in and they say I have a band and I've had problems with my band, first of all, you have to know that there's different types of bands. There's fixed bands and adjustable gastric bands. The most common bands out there are adjustable gastric bands, things like LapBand, Realize band, things of this nature. But there's also, before those bands were used a lot, there were these fixed bands being done, which were made out of Dacron or Marlex or Gore-Tex or Celastic bands, and there were these things such as vertical banded gastroplasty or pure fixed bands. Sometimes they're called Molina bands or Wilkinson bands, and these were just fixed bands put over the upper stomach, sometimes with a staple line, sometimes not, and those can cause problems with obstruction. And a lot of patients who had these band procedures, the reason they're not done in a routine fashion today is because a lot of patients had obstructive symptoms and had problems with the band, and they had to end up getting them off. There's a lot of patients that still have these bands and they're doing okay, but oftentimes the stomach will dilate above the band, and the patient will have lots of reflux issues, not be able to tolerate solid food, and you'll have to deal with something to deal with the obstruction and the poor emptying of that upper pouch above the band. So we actually can get these bands off, and I want people to know about this because we can use stents, and we have done this for quite a while now, to actually get the bands off of the stomach without surgery. So these are stents that you can put inside the stomach across the band, and you leave the stent in. It basically sits inside your stomach around the band and puts pressure on the band, causes the band to actually erode into the stomach, and you can get the band out without actually having to operate on the patient, because sometimes these operations were done in an open manner. There's lots of scar tissue to go through, and there's a lot of risk involved in order to get the band out surgically. Sometimes it even is risky enough where you can cause holes in the stomach trying to get the band out. So an endoluminal approach to remove the band without that type of risk is now being done, and we help champion and create this, and that's what we do in patients that have fixed bands out there. So this is a band that's been eroded, and it's sitting inside the stomach, and then we took it out. We have ways of getting bands out that have already eroded through inside the stomach. So if you have an eroded band, or you're told you have an eroded band, I think it's important to know that we can get it out from inside your stomach, and you don't have to have surgery to go and do that. It can be done endoluminally. Like I said, there are treatments that are endoscopic or down the mouth that don't involve surgery anymore, and that includes getting rid of some of these old bands. Now, lap bands are bands that have a balloon inside of them and are adjustable because they have a tubing and attached to a port. These bands can also erode, but they can have other problems as well, as slipping, associated hiatal hernias, difficulty adjusting, and you have to consider doing something with the band when this patient starts having problems such as this, and I'm going to talk a little bit about that. So here's what a band looks like when it's slipped. There's a big pouch above the band. There's supposed to be a tiny little pouch above the band, and when the pouch gets really big because the band is rotated down, you have to reoperate on the patient, take the band off, or convert the patient to something else. Occasionally, if it's a small slip, you can deflate the band. The band will reposition itself back into a normal position, and then you can start working with the patient again. But if you have a significant slip, such as this picture, the band will have to come off or be repositioned or replaced. What happens is when you do that is you take the band off and move the band back up into a more normal position where it sits like it's supposed to in the very upper aspect of the stomach. This is an erosion of a lap band. This can be a big problem because it will result in a port infection usually. So if you have a lap band and your port is red or irritated or tender, you need to get a scope to look and make sure you don't have an erosion, because if one part of the band is infected, usually the entire system gets infected, and it means the entire thing has to come out, and you've got to do something else down the road for the patient's sense of satiety. So this is what it looks like when it's eroded. So for patients out there, if you have a lap band and your port's tender, you need to go get checked out, come and see somebody and have them evaluate you, and you need to get an endoscopy where we put a scope down and look at your stomach and make sure that the band's not eroded. If you have an exposed port or something like that, you probably do have an eroded band and it needs to be taken out. Sometimes these actually can be taken out without putting a scope back inside the abdomen or opening the patient back up. You can do them endoscopically and avoid surgery in those patients as well. The band could just be kind of slowly migrate down without fully slipping, and you can get a pouch dilatation above the band. That makes it difficult to adjust the patient. And the patients don't feel like they're adequately adjustable. When the band moves down or slips, patients present with nausea, vomiting. They often are able to eat more because that pouch that's above the band, that's big now, can hold more food, but they also end up throwing up. And generally how you treat it, like I said, you can deflate the band, hope that the patient gets better, but if they're having significant symptoms, oftentimes you have to do something else. There is a problem where patients feel like they don't have a green zone. If you have a band, then you understand there's an area where your band's adjusted when the balloon's filled, where you feel optimal, meaning you're not hungry with a small amount of food. And then, of course, there's an area of adjustment where you're hungry between meals, your band's not tight enough, and then there's also when your band's too tight. So the purpose of a band adjustment is to get into this green zone. Well, on occasion, when a patient has a pouch dilatation or the band slipped a little bit, then that green zone can kind of disappear or it can get very tight. And so when you come in and you get adjustments, either you're too loose or too tight, and you just can't find the spot where you feel good with eating a small amount of solid food and feeling full. And when that happens, there's often pouch dilatation or an associated hiatal hernia, and you have to go in surgically and reposition the band or consider doing something else. The problems of this are probably due to patients having their band overfilled for too long. If you push a band too hard and try to lose a whole bunch of extra weight just by having the band tight for a long period of time, the band's going to fail ultimately. You'll get esophageal dilatation or pouch dilatation, or a hiatal hernia will develop because of pressure on the diaphragm from a chronically tight band. So what you need to do is, first of all, if you have a band, don't push having your band too tight for too long. If your band is too tight and you're in the red zone over here where you're having difficulty swallowing, lots of reflux, problems with regurgitation, not able to tolerate solid food, if you're having that types of problems, you need to get your band unfilled, or you're going to have ultimate problems where your band's going to have to be taken off. So a band is something that needs to be monitored and taken care of chronically long term for it to be successful and not end up needing to be taken off. When you do start having problems that require you to have surgery for it, though, what you end up having to do is consider converting it to some other procedure, taking the band off and converting it to a gastric bypass or a sleeve gastrectomy, or in rare circumstances even a biliopancreatic diversion is an option. You can do this in staged approaches. Taking the band off first and then later doing something else is probably slightly safer than doing it all at once, taking the band off and immediately converting it to a bypass or a sleeve. But those are options to do it. So let me talk about gastric bypass. So gastric bypass is a very common operation, has been around for many, many years. It's kind of the old original bariatric surgery that's still around and still working well. but it can have problems as well. Your weight can fluctuate. There's really no adjustment to it because once you get the operation, it's kind of done. And people tend to lose a certain amount of weight, 60 to 70% of their extra weight. They lose a lot of it in the first 6 months to 12 months, but continue to lose weight up to 1 to 2 years oftentimes. And depending upon their behavior, they can gain some weight back. Some of the problems that can occur with bypass is you can get some narrowing or strictures. Those are usually temporary, but they're at a higher risk when you have a revisional procedure or get converted to a gastric bypass from some other procedure. And then bypass has a couple of unique problems: marginal ulcerations and internal hernias. So if you have problems with epigastric pain or things like that, then these need to be diagnosed. So let me talk a little bit about marginal ulcers. Marginal ulcers are usually a burning type pain. It feels like you have an ulcer in your epigastric area. So if you have a gastric bypass and you're having a lot of burning, then you should probably get checked out. It sometimes can make you feel like things are hanging up. It's more common to occur in patients who smoke. So if you smoke, you really should stop. But if you're a smoker and you have a gastric bypass, you're at a risk for having a bad ulcer, which could perforate and even be dangerous. So but if you're having epigastric pain and you're a smoker and you've had a gastric bypass, you need to get checked out with a scope and look for an ulcer. Also, patients who take a lot of aspirin, Aleve, Motrin, ibuprofen, what we call non-steroidal anti-inflammatory drugs, those patients can also have ulcers, and what we do is put a scope in. And so this is what a marginal ulcer looks like. Here you can see what it looks like, and sometimes we can treat these very effectively medically with medications, and they can heal up. We have the patient stop the medications that could be contributing to the ulcer and stop smoking. That can help heal it up. But we can also use suturing, endoscopic suturing down the mouth to oversew these on occasion. So sometimes we can do a procedure to help a marginal ulcer without actually having to do more surgery. If the ulcer will not heal, sometimes you have to go back and surgically fix this. But the endoscopic suturing that we do now allows us that ulcer to sometimes heal without actual surgery. Internal hernias are where the bowel rotates on itself because the intestine was swung up to the upper stomach, and it creates a defect. These defects get closed when you do a gastric bypass, but sometimes they open up, and the patients present with crampy abdominal pain, nausea, and sometimes vomiting. And we do a CAT scan to look for dilation of the bowel, and sometimes we put a scope in it to look around. It's more common to occur in patients who've lost a whole bunch of weight because their mesentery, or the fat planes that hold the blood supply to the intestine and stomach, have thinned out to the point where they develop a defect that the bowel can rotate around. So what can you do for bypass patients that have problems from weight regain? Well, there's actually some endoluminal therapies that we're now doing for improving pouch size and stoma size, which I'll talk about. And then you can do other things like redo the gastric bypass, or even adding a band to the bypass. So if the patient's had weight regain and they've had a gastric bypass, we check for things such as abnormal connections between the upper and lower stomach. The upper pouch is supposed to be completely separated from the lower pouch. Sometimes a small connection, which we call a Gastro-gastric Fistula, can be significant in that it changes the way the patients feel as far as hunger, and it can really affect their ability to maintain weight loss. So we can surgically go in and make the pouch smaller. We can surgically go in and make the connection between the pouch and the intestine smaller, or we can do it endoluminally, or we can change the limbs of the bypass, and I'm going to show you some of those things. So using endoscopy to make things smaller, this is a study that shows in patients that have weight regain, the larger their outlet of their connection between their stomach and the intestine, or the stoma, the larger that outlet is, the more weight regain patients can have. So patients with very large outlets tend to have more weight regain than those with smaller outlets. So you can actually go in and make those outlets smaller. You can inject the outlet with a sclerosant, and that can make the patients feel a more sense of restriction and satiety. So that's one way of making it smaller. This is basically a picture of injecting it and making the outlet, the connection between the stomach and the intestine, smaller. Usually this requires multiple injections, which means it requires multiple endoscopies. So another option that we've developed is using suturing techniques. So these are different types of endoluminal suturing devices that go down the mouth, and I'm going to show you one of them that shows kind of how you go down and make an outlet smaller. So this is called an overstitch, which is an endoluminal sewing machine. So it's basically all down the mouth, and this is showing a cartoon of an outlet. And then you can use this sewing machine on the end of the scope, and so it's a one-piece scope, and you can go down and put some stitches across the outlet and then narrow it down. So you have this little grasper, it's called a helical retractor. You use it to grab the edge of the outlet. And people often say, well, what's the optimal size of an outlet? Well, but the gastrojejunostomy, or the connection between the stomach and the intestine, optimally, when we do the operation, is set up to be about 1 centimeter to 1.5 centimeters. But then over time, it can dilate up to 2 to 3 centimeters. That's 1 inch to 1.5 inches even. And sometimes that can result in patients feeling less full and more hungry. So we can go in down the mouth and actually re-narrow that back down to that 1 centimeter diameter with using this stitching and this sewing machine. So this just kind of shows how you do it. So you stitch from the inside of the stomach pouch and the intestine and sew it down that way. So that's how you narrow it down. And the goal would be to make a small connection again. Let this fire one more time and show you after you cinch it down what it looks like. So obviously you can take an outlet that was well over 1 inch to 1.5 inches or 2 inches in diameter, and you can make it much smaller, like less than 1/2 inch. You can also use this device to reduce the size of the pouch, which probably isn't as important to reestablish satiety and help people lose weight. But if a patient comes in and they've had a gastric bypass and they've lost a whole bunch of weight, but now they've gained about 20 pounds back, and they want to do something to kind of reestablish some restriction, we'll re-educate them and then consider doing this, and with the goal of trying to get them back on a weight loss pathway. These operations don't generate massive amounts of weight loss, but if a patient's looking to try to get 20-30 pounds off that they've either regained, then this could be very helpful with good support around it. So here's kind of an example of what happens if you utilize this as a small study that shows how much weight you can lose, and it's somewhere between 15 to 30 pounds in patients when you use an endoluminal suturing technique such as this. This is an example of a gastrogastric fistula. I talked a little bit about that. You can actually sew this down as well endoluminally, but sometimes you have to surgically go in and do this, which has a little bit more risk. This is using a band on a gastric bypass to increase weight loss by inducing more restriction. This is not commonly done, but it has been done some. The issue is the band sits on a pouch that has staples on it, and there is concern that the band could have a higher risk of erosion. So we don't do it a lot, but it is an option for patients, and we've done it on occasion. Then also surgically, you can go in, just like you can go in down the mouth endoluminally with lower risk. You also, though, can go in surgically and redo everything. That's a little riskier. It obviously requires more laparoscopy to do it, but that's one of the things that we also do on patients where their pouch is extremely large or the intestinal limbs aren't the right length and we need to change the length of their intestinal limbs. So if you look at patients that have had bypasses and they're having problems with them, and they've had excess weight loss that's not nearly as what they wanted, you can add intestinal malabsorption. You can redo the whole bypass or add a band to the bypass and get people closer to that excess weight loss of about 60%, which is kind of the average you would see. But there's some risk to that. A revisional procedure or a revisional gastric bypass has a higher risk of stenosis, leaks, and bleeding, substantially higher risk than doing it the first time. So when you go back and you reoperate on a patient laparoscopically, the risks are significantly higher for some of the complications, such as narrowing and leaks, and that's why we often talk about these endoluminal approaches. Because if you go down your mouth, you're reducing your risk dramatically. There's really almost no risk of having a leak if you're doing it down the mouth. So that's one of the reasons we offer this to patients. The other thing is when we do our revisional procedures, we actually use robotics, and we're well known for that. And we think in robotics in revisional operations, robotics really allow us to be much more precise. This is basically a console that allows us to be extremely precise with you. We're still doing the operation, but we have a computer between us and the patient, and allows us to be more precise, see in 3 dimensions, have wristed instruments, have a very stable platform to operate on, and it allows us to do much more accurate surgery, and it's actually resulted in us having lower complications when we do bariatric surgery, especially revisional bariatric surgery. So when you compare standard laparoscopy with leaks and compare that to robotic surgery, we have a much lower leak rate doing it robotically. So that's why we lean to doing either something endoluminally, or if we're going to go back and do something laparoscopically, we use robotics to help us with that procedure to make us much more safe and accurate. Biliopancreatic diversion. So it's probably the most aggressive procedure for weight loss, and you'd say, well, why would anyone need a revision for biliopancreatic diversion? Well, sometimes these patients have significant malabsorption issues, and they have to be converted to something else because they're too malnourished from the operation. That is the risk of a biliopancreatic diversion. For those that don't know about it, it's a sleeve gastrectomy with a very long, aggressive bypass of the small intestine. And so patients can actually have significant malabsorption. So patients will come to us sometimes with this operation and they're too malnourished. They can't maintain their vitamin levels, they can't maintain their protein stores, and we have to figure out some way of improving that by reducing the amount of malabsorption that they have. And so that is there are biliopancreatic diversion patients that have to be revised as well because of those issues. If you have a BPD, or a duodenal switch as it's called, and you have significant swelling of your legs, edema, neurologic changes, this all can be due to protein deficiencies, vitamin deficiencies. You need to be evaluated. That's why it's so important that patients who get bariatric surgery have long-term follow-up, so these things can be monitored. Because some of this stuff can be reversible and some of it is not. So if you had some of these more aggressive procedures, you need to be followed. Patients who have had gastric bypass, one of the things that we've done on rare occasions is actually convert them to a BPD as a method to induce more weight loss. But you can, again, make a patient too malabsorptive and have them get malnutrition if you get too aggressive. So patients who have gained a lot of weight back from bariatric surgery, as a surgeon, I will tell you can almost always get them to lose more weight, but that doesn't necessarily make them healthier. Because if you're not eating the right types of food, no matter how aggressive we get, if you're eating really bad food, you're going to be unhealthy. You may be thinner, but you'll be very unhealthy. So it's important to eat properly no matter what procedure you get. And just relying upon the procedure in and of itself, no matter how aggressive it is not going to work long term. So I can't really stress that enough. It's important to make sure that you understand how to eat with your tool, and that'll allow you to be more successful long term. Sleeve gastrectomy. It's actually probably the procedure that's extremely popular right now, but also the easiest to revise. So I think a lot of people are considering sleeve gastrectomy as an option these days, and we'll have patients that don't lose as much weight as they need to with a sleeve gastrectomy, and will be converted to other things, but it basically sets up pretty well to be converted to other things. The problem with sleeve gastrectomies most commonly are two things. Probably not losing much weight as you want to. The average weight loss with sleeve gastrectomy is closely around, usually around 60% extra weight. But there are patients that get pretty significant reflux after sleeve gastrectomy. They probably had bad reflux before their sleeve gastrectomy, but if you have pretty bad reflux after sleeve gastrectomy, it could require a conversion to something else like a gastric bypass. The revisional options are to re-sleeve if the pouch gets big and dilated, placate it down either laparoscopically or endoluminally, repair a hiatal hernia if the patient has reflux and they don't want to be converted to a bypass, or convert the patient to a bypass, or put a band on it, or do a switch, or other things such as that. A sleeve to bypass is a good option for people who have significant reflux, and it's a relatively straightforward procedure to do. I would not say it's overly dramatic with weight loss, but it does produce some weight loss. But the purpose of doing sleeve to gastric bypass in most situations is due to reflux. So let me kind of summarize up. I know I've talked about a lot of information. Obviously, revisional procedures are much more complex than standard laparoscopy. Just like obesity is a complex disease. Like I said, we don't really have one simple way to treat obesity. We need to use every method available to us, including excuse me, medical weight loss, surgery sometimes, and even these endoluminal procedures. Revisions are going to be necessary, but they require extra commitment from both the patient and the team, and there's lots of procedures out there and more are coming. I think it's important for us to focus on weight loss and but also focus on improvement of health and improvement of quality of life. And if a patient hasn't lost as much weight as they want, but they're still very healthy and their quality of life is better, then we also should appreciate that and think about that when we're looking at the risks of doing something more. We should combine medical and surgical therapy whenever we can. And as far as for the patients, I would say you can't really improve something unless you measure it. So when we have patients come in and they want to do something else, oftentimes we'll analyze them pretty well. We do body fat analysis, metabolism analysis. We'll have patients come in and they'll say, I'm not eating anything and I'm just not losing weight. And so then we'll measure their metabolism and find out what their metabolic rate is and figure out whether they need to increase their metabolism by focusing on muscle training like we talked about earlier, or how they're eating, focusing on protein intake, and truly figure out how many calories they're taking in with calorie counting. It's very easy to do calorie counting these days with apps on your phone such as MyFitnessPal and FitDay and things like this. So all of these things are important to measure what you're doing so we can evaluate what you're doing and hopefully help you improve that. Follow-up is critical, and patients do better when they come in to see their doctors because it allows them to stay on track and stay focused on what they're doing and not ignore their behaviors as much. I think it's important for us to always keep educating the patients because inducing change in someone's behavior is extremely hard to do and it requires a lot of work, but it is doable. To summarize up, it's a tool. Surgery is a tool to help obesity. It's not a cure. Revisions are riskier. It's a journey going through weight loss. So just getting a procedure does not fix the whole problem. You're going to be dealing with weight loss issues long term, even if you've had bariatric surgery or not. And you got to remember where you started when you began because it's easy to beat yourself up. So I tell patients over and over again, don't beat yourself up if you've gained a few pounds back, but come back in and get reevaluated and see what else is possible and see what we can do to look at how you're eating, what you're eating, how you're exercising, what your emotional ties to food are, as well as what could be mechanically wrong with the tool. If you come and see us, just so you know, we have a dedicated seminar like this webinar where we talk to patients about bariatric revisional procedures. We have a dedicated group evaluation, meaning that after you come in and see us, our entire group will look at you as a group and discuss your case and figure out what your best options are. And we promote very aggressive education. Usually you have multiple nutrition visits preoperatively. We'll give you a preoperative weight loss goal to help you kind of get on track even before we reoperate on you. And also we'll have you do some measuring such as food journaling, goal setting, and weight recording to make sure that you're headed in the right direction even before surgery. And then psychologically, we'll often encourage you to join food addiction groups or food addiction classes to evaluate that and do a thorough mechanical evaluation. So revisions the purpose of a revision is to do it one more time, not 5 more times. So our goal is to make sure that you're very well educated when you get that revisional procedure. So it is the last procedure you need for weight loss because you're able to maintain a good and healthy weight long term. So I want to thank you for your time. I know I went over a lot of information. If you have more questions, feel free to come into the clinic and talk to us. We're also located, you can find our clinic on our website at www.utmist.com, and also the Memorial Hermann Texas Medical web.